Welcome to Chatting Shit with Ostique, the podcast series where we chat about shit with inspirational people from all walks of life. Today we are joined by the wonderful and inspiring Dr. Mark Samaan and Dearbhaile O'Hanlon. We hope you enjoy this conversation. Hello both, welcome to Chatting Shit with Ostique. Thank you for being here.
Hi.
Hi, Liv.
Today we are going to be covering managing high output stomas, and this, as you both know, is a topic that we see come up time and time again. We get tons of questions on it. Either someone who has always had a high output stoma and just really wants to understand if they can manage that or change that, or people that are triggered by certain things and would love to either figure out what those things are or find out what they can do about it. So this will definitely be really useful. Before we delve into all of the questions, would I be able to ask you both to introduce yourselves and just give a little bit of background as to what you do? Mark, maybe you go first.
Okay, sure. Liv, thanks for having us on. My name is Mark Samaan. I'm a consultant gastroenterologist at Guy's and St.Thomas in London. And I have an interest in inflammatory bowel disease. And so I look after lots of patients who have ostomates.
Thank you.
And I'm Dearbhaile. I am a senior specialist Gastro Dietician, and I'm also at Guy's and St.Thomas's. And again, kind of predominantly working with people with inflammatory bowel disease and pre-op nutritional optimization and lots of post-op nutritional optimization, and of course hydration and nutrition come into that for ostomies. Yeah.
Fab, thank you. So when Mark and I spoke earlier, we kind of discussed the fact that you have seen quite a lot of high output stomas. What do you think the causes of that might be? I know that's quite general.
Well, I suppose the first thing is that it's not unusual for anyone with a stoma to temporarily or transiently have high output. And we tend to define how high output as being something more than maybe 1.5 litres a day. Some people might say more than a litre, but it can be many, many litres more than that. You know, you can have a high output stoma up to 3 or 4 or 5 or 6 litres, you know, in a 24-hour period. And even the sort of the measurement of a stoma effluent is not the easiest thing in the world to do. So the other way you could look at it is looking at the stoma consistency, and if it's very, very watery, then that's another signal or a sign that the stoma may be high output. And so I think I read that about a third of stomas at some point will be high output when they're, you know, especially when they're first made, even if someone has got a full complement of normal small bowel left and they just had the large bowel, the colon, removed. And so it's probably something that we should prepare people for when they're having a colectomy or having a stoma made. And it's probably something we don't do quite well enough because there's a lot of other things to prepare someone for when they're having you know, a colectomy or a stoma made for another reason. So the cause is just sometimes that's a normal physiological result at first of having an operation and having been quite unwell, which a lot of people with inflammatory bowel disease are at that point. And it can just settle down as someone gets better and recovers. That's not true of everyone. And I guess what we're talking about here is high output stomas that kind of don't settle down and are high output kind of into the medium to long term and will continue to be without kind of intervention. But there is definitely a proportion of people who have high output at first and then settle down and go back to a more normal output and a controlled output without really us needing to do much. In terms of medicines, they almost certainly will have some discussion with our dietitians about how their diet might be modified, but not everyone needs the medications that I'm sure we're going to come on to discuss.
Dearbhaile, before we do delve into medications, do you have any different viewpoints as to what you think might cause a high output stoma?
I don't think I have different viewpoints, but certainly I think one of the other like big things is where the stoma is and bowel length and bowel quality and as Mark said, you know, what happened before that? Was there lots of inflammation? Was there a tumor? Was there something that was making the, you know, what we would say upstream bowel behave differently? So certainly bowel length will have a huge impact, and I'm sure people out there who have colostomies, they have much firmer output than say an ileostomy would have, and a jejunostomy, output is incredibly challenging with a jejunostomy. So depends on where the bowel it is, really. And then I think, diet and hydration definitely will play a role for a lot of people. And again, that can be a real kind of journey, if you like. I don't like the term journey that often, but it can be, post-op to kind of, recovery, and then more long-term, what's happening. That can change hugely and the need for diet and hydration can change a lot in that time. And then like loads of other stuff. And I think we kind of, I'm sure this comes up a lot, but things like, where somebody is in their menstrual cycle, whether or not they've got a cough, a cold, pick up a little bug that they might be a bit more susceptible to than they were pre-operatively. So there can be like little peaks and troughs, and that doesn't necessarily mean that they have a completely high output stoma. You can have a high output for a day, or you could have a high output for a morning, but what's more concerning is if it's consistently always liquidy, no form to it, and you're losing all that fluid from your body. That's the concern, really.
And it's probably worth, at this point, just sort of talking a little bit about the anatomy, isn't it?
Yeah.
Because it's not necessarily obvious to everyone, or they might not know, is that, the stomach and the duodenum are largely secretory, lots of juices, gastric juices and things that digest, and bile and pancreatic juices come in there. And so everything there is really quite liquidy, and that's the whole point, to digest your food. And as it goes down through the bowel, through the jejunum, that Dearbhaile mentioned, if you had a stoma there, then what comes out, like you said, is almost entirely liquid and very high volume. As you go further down the bowel into the ileum, which is the last part of the small bowel, you can get more absorption, and the stool becomes a little bit more porridge-like, is how we kind of tend to describe it, or aim to achieve a kind of porridge-like consistency for an ileostomy. And Dearbhaile mentioned that if you in fact have a stoma that's made of colon, so you've got some of your colon still in connection, then actually the colon's really good at reabsorbing water. That's kind of all it does, really. And so actually the stool that comes out may be like stool that you'd pass normally with your full bowel intact. So it's worth kind of people knowing where their stomas are, and it helps them to understand how it behaves in a way.
And I guess how their output should be, so they're understanding what's normal versus not normal, if you will.
You can get constipated if you've got a colostomy.
I didn't know that.
Weird, yeah.
Okay.
So if you take the constipation...
No, I can imagine.
Right, it's weird. So if you take codeine for pain, which is really quite constipating, you get constipated. So
And you don't have a rectum to squeeze that out, so it's not very pleasant to try and clear that fluid.
So it can go the other way. Not so.
We're going slightly off piste here, but if that does happen and you can't obviously clear it yourself, what do you do if you get constipated in that way?
Well, I mean, what you normally do if you're constipated, you take laxatives.
Oh, okay.
Or you stop the offending medication. You stop the thing that constipated you and take something that would help to relieve the constipation. So it's kind of unusual. It's rare, but it can happen.
So in terms of managing high output, what would your top tips be? And I know we're kind of going to go in two directions here, but I guess they also work together. So Mark, I know you were going to cover kind of a medication and drug perspective, and then Dearbhaile, we can move on to kind of nutrition and hydration.
Yeah, so and it is really important, like you said, Liv, that these two things are done together, synergistic. They work to improve the outputs together in different ways. So and it may be that it's often that people start with dietary modifications and fluid changes because it's less interventional, it's less involved taking medications, but as Dearbhaile will come on to discuss, they're not always entirely easy to follow to the letter into the long term. So most people with high output stomas do require medication. And the medications, it works in a number of different ways, and there's a number of different medications that we tend to use. The first is, I mentioned that the stomach secretes a lot of fluid, And you can stop the stomach secreting as much fluid by using anti-secretory medications. And they're the same medications you use to reduce gastric acid. So they're a group of drugs called proton pump inhibitors, or PPIs. And they're really common. You can get them over the counter from Boots or wherever. They're the drugs called like omeprazole and lansoprazole, esomeprazole. There's quite a few of them.
Yeah.
And they can be used to reduce gastric acid secretion. And I guess you'd call them modestly effective in that regard. Beyond that, but they're well tolerated and they have relatively few side effects. One that's relevant here is that they can sometimes reduce magnesium levels in the blood, which is kind of an issue with a high output stoma, because magnesium is often an issue or can become an issue. Beyond that, what you actually want to do is make the stool stay as long as possible in the small bowel before it comes out, to give it the best chance of having as much water reabsorbed. And so what you really need to do is slow the bowel down and just make it sort of not stop working altogether, but really slow it down so that the transit time is much longer. And you use the same drugs that you'd use when you've got your colon in continuity, if you've got diarrhea. And so you use things like Imodium, which is a drug called loperamide. Imodium's the brand name, but it's just one and the same. And the other thing you can use to slow the bowel down, and I mentioned it before, is something like codeine. And both of those work in exactly the same way on the bowel. Codeine also has the pain-killing kind of, sometimes nauseating, sometimes sedating effect, whereas loperamide doesn't have any of those effects, pain, nausea, or sedation, because it doesn't get into the brain, it doesn't cross the blood-brain barrier, and so it just works on the gut. And so that's why we prefer to use loperamide in the first instance. Sometimes we use them together. The slight caveat here is that when you don't have a colon, you have to use sometimes have to use industrial doses of loperamide. And this is really hard for not only patients to get their head around, but also doctors who don't work in intestinal medicine, who aren't surgeons, really struggle to get their heads around this. And that includes general medics or people who specialize in other parts of the body, or general practitioners. Because actually loperamide and codeine they work largely constipated. Their constipating effect is working on the colon. When you don't have a colon there, you have to have much higher doses to get that same constipating effect. And so if I give you an example, that I think the top dose of loperamide when you've got a colon in situ is something like 8 milligrams, let's say, a day. So that's 4 tablets. I think you can take a bit more if things are really bad, but you often don't need to. Whereas if you haven't got a colon in situ, so you've got an ileostomy and you've got really high output, we can use doses anywhere up to 24 milligrams, that's 12 tablets, 4 times a day.
Oh, wow.
Right, exactly. So you wouldn't start at that. You'd never go in, but you might go in with 4 milligrams, 2 tablets, the 2 milligram tablets. So you go 2 tablets 4 times a day, and then you might go up to 4 tablets 4 times a day. And for some patients, not a minority, a reasonable proportion of patients, you get up to using 12, 16, 18, 24 milligrams 4 times a day. So that's a lot.
That's a lot.
It's a lot of pills. It's a lot of pills to carry around. The fact the half-life is relatively short, so you take them 4 times a day. It's a big pill burden. It's a big burden on people. And codeine, it tends to be fewer pills, but it has more side effects. So there's issues there, and codeine in some ways can be addictive as well. So you prefer not to use that unless you necessarily had to. But those are the 2 main pharmacological ways to slow down a high output stoma. But I appreciate it's quite a lot to take on for patients, especially the loperamide dosing.
And once a patient starts this kind of course where they're taking this 4 times a day, do you find that they tend to need to continue that for the lifetime of their ostomy, or does it kind of go up and down? How does that work?
Yeah, so there is some adaptation of the small bowel, and it becomes in some ways more colonic. It kind of the body's really intelligent, and it's there's a lot of plasticity in the bowel and other parts of the body, but it can sense that you don't have a colon in situ anymore to absorb water, and that you need to absorb water. And so actually there is some changes in the lining of the small bowel that allow it to absorb more water. So it may well be that the output comes down naturally, as I mentioned earlier, or it may well be that the amount of medication you need to take over time reduces. So it's not always the way, if in people who've got very short lengths of small bowel remaining, or the small bowel is inflamed or ulcerated, then often they would be on very high doses into the long term.
Wow. And then from a kind of diet, hydration, nutrition perspective, what should people be doing to support any medication that they might be on?
So normally when somebody has a high output, we would start with adjusting the fibre in their diet. So fibre is typically found in fruits and vegetables, nuts and seeds, and whole grains. And as you probably, this all rings a bell as being really healthy food. So we ask them to take that down, take that out, really minimize it, because fibre, there's kind of two types of fibre. There's what we call insoluble fibre, and that's like the roughage, it's the skin, the pith, the seed. That's the type of fibre that when we eat it, it kind of signals for our bowel to move and that there's something there. So it helps with motility. And when you've got a really high output, you don't need more motility. As Mark just said, we want to slow things down. And then you've got the soluble fibre, which is in like the juice and the flour and all of that kind of inside of the fruits and vegetables. And that can be quite binding, but also can help to promote that motility. So we would try and reduce that and really minimize that, maybe to, very little, or maybe like a little bit of juice or some tomato sauce or something, but really quite minimal. So that's the first thing, slowing it down by avoiding those foods that promote motility. And then it's really important that people are still getting enough nutrition, because if your bowel's moving very quickly, sometimes the nutrition that you're eating isn't being absorbed quite as well as it should. And again, part of that will also be about bowel length. So ensuring that you're getting enough protein, so from kind of meat, fish, eggs, the plant-based and vegetarian, vegan proteins are a bit more challenging because they tend to be quite high in fiber. So it can be really challenging on those types of diets. And enough carbohydrate, but those carbohydrates, so potatoes, rice, pasta, breakfast cereals, they need to be the really refined, rather, so the white versions, the stuff that doesn't have the whole grain in it, and that way they're getting enough energy and enough protein to manage. But then on the hydration front, because the fluid is being washed through into the bag rather than being retained as well in the body and circulating through your kidneys, it's really important that you get the right balance of hydration. And it often sounds really counterintuitive, because if you have a high output, you're often incredibly thirsty. And we will probably ask you to take something called oral rehydration solution, which is a mixture of sodium, glucose, and salt. Well, salt is where you get the sodium from, and bicarbonate. And this basically mimics the same concentration as your bowel wall. So it stops the kind of water being dragged into the contents, and then the salt following it, and then the water following it, and then the salt following it, and basically it all just ends up in your bag. So even though it's very salty, kind of weird combo of salt and sweetness, what it does is it stops this dragging effect of fluid and salts from your bowel wall and basically from your body. And that's one of the things that I'm guessing most people will probably be feeding back to you as one of the most challenging bits about having a high output, but it's also one of the most effective ways of actually stopping the drag and that cycle. So we'll sometimes, particularly in that acute phase of the high output starting, would say that's one of the best things to do, is to predominantly drink this oral rehydration solution. So up to a litre a day, more if need be, and actually limiting other fluids. So limiting water, teas, coffees, milkshakes, limiting all of that to a litre, 500 mils. It depends on the severity. And really, if you've got a good going high output, hopefully there will be a medical team or dietitians who will be giving you some advice on this. But yeah, that would be the first thing I would say. And that then, depending on the drug therapies, can be adapted over time, reduced over time. But it's also worth mentioning, as Mark was saying, about the really high doses of loperamide, and that a lot of health professionals aren't really aware of that this is required. That you might find that you might go into hospital with a high output stoma, and if you're in an admission ward or an A&E, people might be saying, well, your kidney function's reducing and you're losing all of this fluid. Drink more water, drink. And it's definitely not the right thing to do, okay? So it's because they don't understand that, and actually understanding that in that time, if you're drinking loads, it needs to have that balance of salt and glucose in it. So the oral rehydration solution is so important. And then there's other little things that can make a big difference, like chewing food, taking time over your food, and just like really breaking it down, and adding a bit of salt to your food, and even adding a bit of sugar to your food. Because one of the ways that salt and sodium gets absorbed is when it's kind of piggybacked with glucose, which is found in sugar. So having sugary, salty food can be really helpful as well. This all sounds incredibly unhealthy. I appreciate that, but you have to remember that in this context, a lot of what you're eating isn't being absorbed. So it's not like when you have a complete bowel, where if you were just having sugary, salty stuff, you get high blood pressure and you might get, raised blood glucose levels. It won't work the same way, because this is trying to salvage your hydration and give you what you need to absorb. So it sounds really counterintuitive, but that would be the advice. As things slow down, and if you're in a really acute phase and you're doing medical therapy, so you're taking your loperamide, you're taking your codeine, you're taking your PPIs, you're on a fluid restriction with some ORS, you're on a low fiber diet, it's going to work at some point. And once that starts to work, then you can start taking bits of that back and seeing how to maintain that. And again, that's probably a discussion with your team, because for some people, they would far rather be off the pills and would be fine with a low fiber diet for the longer term. And for other people, they just want to get off the ORS and be able to eat some fruits and veggies, in which case they might be happier to stay on the pills. So that's something to have a chat to your team about. But obviously, if you're not eating your fruits and vegetables, you need to be on a good quality multivitamin as well. So ensuring that that's being prescribed through your GP, or if you're buying one, that it's kind of one of the good quality branded ones.
And what would your recommendation be for a good quality branded multivitamin?
So probably like the bigger pharmacy brands, or the kind of Well Woman, Well Man kind of brands. And there's a Forceval, which is on prescription. And really, again, if you're having a high output stoma, that's a clinical issue, and your GP should be prescribing you that. So if you're having to adapt your diet because of health reasons, there's a good reason for your GP to prescribe a decent multivitamin. So Forceval would be the one that I would recommend.
Perfect. And a few people I know who have high output stomas find that, obviously, because of all these dietary changes you need to make, they're concerned about either weight management, and that goes two ways. I know several people who struggle to keep their weight down because they can't eat healthy foods. And then also the other way, where people struggle to keep weight on because of everything that's going on. For both sides of that, so perhaps we need to take them in turn, what would your recommendation be for managing weight under these circumstances?
So if we start with the underweight, the difficulty gaining weight, I think the key there is good protein intake. And so normally we'd say like at least twice a day, have a decent protein intake. Okay. So again, that's meat, fish, eggs, and the dairy products, if they're tolerated, pulses and legumes if they're tolerated, but in a high output, that's going to be potentially quite challenging. But that's growth and repair. And so you need that at least twice a day in normal circumstances. I would say with a high output, try and have that 3 times a day. So that might be like having some eggs with your breakfast rather than just cereal or toast, and having some meat or fish at lunch and evening meal. Eating little and often and trying to have nutritious snacks in between. And again, with the high output, we're not quite as fussy about what those snacks might look like, whether or not they're completely balanced or whether or not it might be some biscuits or some cakes. And this is something that often comes back to me where people are saying, why do you keep telling me to eat so unhealthily? And it's not, I don't want you to eat unhealthily, but in an acute phase, or if there's a clinical need for it, sometimes the biggest risk is being malnourished. And it's, if you're, and being underweight, and sometimes it doesn't look like perfect nutrition, but it's what you need at that time. And if the easiest way to do that is through biscuits or cakes or crisps, then do it. But equally, if you can have like a cheese sandwich, have that as an alternative, right? And then, a good carbohydrate intake. And as I said, not being too fussy with the sugars, but also with high output and any sort of short bowel or shorter bowel issues, having a good fat intake is also really important. So liberally using your fats, and that can be difficult in like family settings or if you're cooking for other people, but just like always having something to drizzle on at the end of a meal, so you're doing it on your portion rather than everyone else's. But just thinking, if I'm going to go to the bother of eating this, could I put some cheese in it? Could I put some cream in it? Could I put some extra oil in it? Could I use some coconut milk? Can I get more into that mouthful? So that would be for the underweight. And if that's a really, really underweight, like a body mass index of less than 18.5, you should probably ask for a referral to a dietitian. And there might be a good rationale for prescribing some oral nutrition supplements. So these are prescribed nutrition that can help to top you up. On the flip side of that, then, for being overweight, it can be quite challenging with a high output to manage the kind of balancing the diet, because we can't say eat crudité and eat, have salads and fill your plate with vegetables. Trying to make sure that your hydration's good, trying to have a regular meal pattern, looking at what it is about your eating habits that might be slightly excessive. So is it that you're eating really quickly, you're not chewing your food or taking time over your food, not hearing those signals of fullness, and considering physical activity and whether or not that might play a role. But that can be a real challenge. And while I know we're focusing on high output, I think one of the things I would say for having anyone with an ostomy is that often you get post-op advice that will almost always be low fiber, high energy, because you've just had surgery, and stomas tend to be high for the first few days or weeks. But that advice often doesn't get untold, and you should, at some point, when your stoma output starts to thicken up, becomes regular and isn't problematic, reintroduce fibers to tolerance. And that's something that we occasionally will see people on their third surgery and be like, hey, what's going on here? You haven't had a vegetable in like 10 years. And they'll say it's because somebody told me after surgery not to eat fiber, and nobody told me that I should stop doing that. So I'm here to say you can eat some vegetables as long as your stoma output isn't high. But if it is, that's more problematic. Yeah.
Thank you. That's so helpful. I wanted to touch on 2 questions that we had submitted. We kind of asked the community if they had any specific questions. One thing which you did touch upon, I think, right at the beginning, is we see a lot of people posting on their social media saying that they've caught a cold or the flu, and it's drastically changed their output, and they don't know whether this is a thing or not, or whether it's just happening to them. So my question, I guess, is 1, is this a thing? And if so, what can people do about it?
Yeah, I think it is a thing. If our patients are telling us it's a thing, and they do, then it's a thing, right? They're the ones with lived experience of having a stoma, and so and physiologically, you could quite easily explain that any systemic upset, and it can be something as relatively trivial as a minor viral infection like a cold or a flu, or it can be when people get you're more unwell and have kind of sepsis, and get kind of more unwell. We definitely see that in hospital, because they're in hospital for being more unwell. We see that their stoma output goes up, and we have to act accordingly. We sometimes use intravenous fluids in that setting, and when when people get better and the infection goes, things get better and people revert to type. And I guess you're just less robust from a fluid shift point of view, because you haven't got your colon there, which, like I said, does all of the heavy lifting with fluid reabsorption. And equally, even with a colon there, when people have a general illness with a virus or whatever, people also get, diarrhea or abdominal pain, bloating. And so I think all of those things are probably just more exaggerated. We haven't got the buffer, if you think of it that way, of a colon in continuity. So yes, I think it's a thing. I don't think it requires necessarily anything specific to be done, except to weather the storm. And you may change your diet temporarily. You may start going to oral rehydration salts if you don't use them, or you might cut down on your hypotonic solutions, of water, tea, whatever, whilst your output is higher. But one wouldn't imagine that would last for very long. Yeah.
Fab. That's really helpful. In terms of pregnancy, for patients who, specifically, this has only actually been asked by patients who have stomas as a result of IBD, so I don't know if that makes a difference. But if someone is thinking about getting pregnant and concerned about how that might change the behaviour of their stoma, A, is it likely that anything will change as a result of pregnancy? And B, if so, should they be managing that in any specific way?
Derv, do you want to go here? You mentioned menstrual cycle earlier, which I thought was really interesting.
Well, I think anything that's going to be so physically changing as well as hormonally changing could, certainly have an effect on your stoma output. Having said that, I don't think that there's any reason that, aside from active inflammation, that you would think it would suddenly go high, completely high, or low even. But we know that for a pregnancy with a kind of bowel incontinuity, there can be, more constipation, more diarrhea, more gas, and I think you could probably expect all of the same with having a stoma. In terms of the only thing I'm kind of would be more concerned about would be the medical management, so maybe mark the safety of those, and also obviously you want to just make sure you're really well hydrated. So if you get a bit of a high output, have some rehydration salts, and do that management strategies that you need transiently. But yeah, I'm just not sure of the safety of the meds in pregnancy.
So PPIs are used quite widely in pregnancy, because in hyperemesis, when women get really sick and often have excess gastric secretions, and so PPIs are used in that setting. And I think the obstetricians are very happy with PPIs, as far as I know, and I don't think there's any concerns in that regard. And loperamide, I think equally, I don't think there's concerns. It's always very difficult in pregnancy to say everything is completely safe, but they're drugs that have been around for a long, long time, and I can't see them being of any concern. And I certainly wouldn't want people to stop their medications if they're on them for high output stomas when they get pregnant, because the concern is then you get into this cycle, like you very clearly explained, Dearbhaile, where the output goes up, you get thirsty, or you get into that vicious cycle. It's kind of hard to break. And the last thing you want when you're in the early stages of pregnancy is to be really dehydrated, and it's very easy to get really dehydrated when you've got a stoma, especially if you're on medications and you stop them abruptly. So I think obviously speak to the team who manage, who look after you, but I would be encouraging that it would be the right thing to do not to stop your medications at that point.
Yeah, and just remember to keep your diet balanced and take your vitamins, your vitamin D and your folic acid pre and at least for the first 3 months of pregnancy. And if you are concerned at all that your nutritional status may have been depleted in any way because of having a stoma or because you've had surgery recently, get your bloods checked, get your nutrition bloods checked, and by all means see if you can access a dietitian for a nutritional assessment.
I know I've taken loads of your time, but I have one more question and then I will let you go. Thank you so much. This has been so interesting. Mark, when we spoke a few weeks ago, you mentioned patients before they have their stoma surgery, so patients with IBD, and the fact that there's some things that you can do from a pre-op optimization, that's hard to say, perspective to give the best chance at successful outcomes. Would you be able to speak to some of those?
Yeah. Again, much like management of high stoma output, this is absolutely a joint effort between surgeons, medical gastroenterologists, and dietitians, specialist dietitians. So I'll talk a little bit about what one might do to try and pre-optimize a patient before an operation, and Dearbhaile, I'm sure, will tell us from a dietetics point of view how this can be done. And it really does make a difference. It can help the surgeon have to take away less bowel, which is really important in this context. The more bowel you have, the better chance you have of having a stoma that works well. And it can improve things like length of stay in hospital and rates of recovery. So often, in the context of inflammatory bowel disease, really, you can have an area of infection around a kind of inflammatory area. So for Crohn's disease, for example, you can have lots of inflammation and then infection on top of it. So it's important to treat sepsis well, and so that can mean antibiotics that go on for much longer than a normal course of antibiotics. So you might go on for 4 or 6 or 8 weeks even, depending on what the infection's like and how it responds. So that's one important thing. The second thing is that sometimes we will change medications at that point to try and control inflammation as best we can, to try and you take the heat out of a segment of bowel, such that in the hope that it may not have to be resected when the patient comes to surgery, which is kind of a newish way of thinking of treating inflammation in the face of a planned operation. But that can be done if we think it's going to be valuable. And then beyond that, I have to say, it's kind of over to our dietetics colleagues, and they're the ones that really make the difference, I think, here, as well as the surgeons, of course.
Yeah, well, I think there's from a Crohn's perspective, there's lots of what Mark was talking about. And also there's something called exclusive enteral nutrition, which is used to treat children with moderate Crohn's disease. And we use it in some adults, but predominantly in children. But we use it to optimize patients who need Crohn's disease surgery on their bowel. And that can help to meet their requirements, particularly if they've lost weight. It can help to take some of the heat out of the bowel that Mark was talking about, in kind of actively taking some of the inflammation down, and it can help to manage symptoms preoperatively. And that, we've seen, helps people get through their surgery a little bit better with less infection rates and things like that post-op. That's quite specific to Crohn's disease and quite specific to Crohn's disease on their bowel, so small bowel predominantly. But then for things like ulcerative colitis, or certainly, there's for anyone who needs surgery for other reasons, for obstructive reasons, for tumours, etc., it's equally important that preoperatively we look at nutritional status. So have you lost weight as a result of your disease? Has that been quite rapid? Do we need to try and get some nutrition into you and build you up a little bit pre-surgery? And depending very much on the circumstance of that surgery, the windows could be quite short. Sometimes they're a bit longer. If those windows are short, then it might be that you need to take some of these nutrition drinks I was mentioning earlier, and they have complete nutrition in them, and they can be alongside your food to try and boost your calorie intake, try and boost your proteins, your muscle mass, and kind of replenish some of your energy stores. And then there's the simple things like, trying to add as much extra fat and sugar and layering up the calories preoperatively, so that particularly if you're struggling with appetite loss or symptoms post eating, and food is a bit of a struggle for you, just making sure that everything you're putting into your mouth, you're trying to pack as much energy in there as possible. And we call that food fortification. So it's literally layering up the calories, using full fat products, full sugar products, all of that kind of thing. And that, again, sounds really weird when you might have cancer, you might have ulcerative colitis, that we're saying, eat lots of sugar, eat lots of fat. It's a short-term thing. We don't want you on that long-term, but it's to meet that requirement. And then certainly immediately pre-op, you want to think almost like you hear marathon runners, carb loading before a race. You want to kind of get into that mentality of, I need to get my nutrition up, but in those day or two pre your surgery, getting as much carb in there as you can manage, because it does actually help. Surgery is a big insult to the body. It puts it into a very stressed state, which sucks up a lot of the energy, the carbohydrate that we store in our body. And so having a bigger load, a bigger store to start with can then help the day after and the next few days in your recovery to just bounce back that little bit easier. So I think it is really important, but it can sometimes be a huge struggle, particularly for bowel surgeries, because almost by definition, you're going to have some difficulty with your digestion. So if you've any concerns about your nutrition pre-op, talk to your team, try and get a dietetic referral. And as a first line thing, just stuff in those calories. You don't have to be healthy about it. Just get them in until you team. Yeah.
Fab. Thank you both so much. This was so helpful, and we get these questions all the time. So I'm thrilled that we can actually point people in the direction of your advice now. So thank you. And hope to see you both soon.
Thanks, Liv.
Thanks so much. Bye. Have you seen the new Ostique skins yet? Ostique skins are revolutionary ostomy pouch covers that were created to make the wearer feel confident, sexy and powerful in all of life's moments. From moments of intimacy to lounging by the pool, conquering a workout or simply heading out to lunch, skins have you covered. Even better, they're compatible with all major colostomy and ileostomy bags. Ostique skins are available in a range of colours and skin tones, and they're made from a revolutionary material that's completely waterproof, high quality, soft and comfortable. Skins are easy to use, even with reduced dexterity, and they work with both closed and drainable bags. Plus, skins are also environmentally friendly and vegan. There are 4 bundles available to buy now, and you can also purchase individual skins. Head to ostique.co.uk to find out more.